I mean, you could be a leopard 2A7, a tiger, a bulldog, a chieftain, a T34.
Okay, the first one.
Okay. So let's say you were a leopard 2A7. I would ask you to marry me.
Doesn't mean you want to marry me?
Are you a leopard 2A7?
Babe?
Yes.
Would you still love me if I was a tank?
Well, it depends on what tank you were. I mean, you could be a leopard 2A7.
Hi everybody, good evening, hello, welcome to another OrthoHub webinar. My name's Ramon, one of the OrthoHub team, and as a hand surgeon I'm really excited to be presenting, or just introducing I guess, tonight's webinar on scaphoid fractures. Just a couple of little bits of housekeeping before I introduce the speakers. We've got loads of content coming up on OrthoHub over the course of the next few weeks, lots of which is going to be relevant for trainees and consultants. Sharon Scott and Pete Bates will be talking about subtrochanteric fractures on an upcoming webinar. We've got some more orthopedic decision-making videos coming up basically about how to treat some really tricky fractures, some of the really challenging things that we all see on our trauma lists every day, tips and tricks. We've also got some ST3 interview preparation coming up, and we've got some video content around that as well. And finally, we've got some great new podcast material that's already been released. Dan Perry and Matt Costa are talking to Cash and Pete on the latest C1 Do 1 podcast. So tune in for all of that. If you're interested in trauma and especially hand and wrist, I released a surgical approach video, the volar approach to the distal radius, and that is now available on our site and on our YouTube platform. Moving on to tonight, first thing to say is that in order to keep OrthoHub free for you guys, we have the kind support of our sponsors. Tonight's sponsor for the scaphoid webinar are Acumed, so thank you very much for making tonight possible and for continuing to support us as OrthoHub. So on to tonight, we're talking about scaphoid fractures, real life situations. What do we actually know about scaphoid fractures? And we've got three fantastic speakers. Speaker number one, talking about acute fractures, is going to be Nick Riley. Nick Riley is a consultant from Oxford who has established himself as being one of the most active members of our Hand Society community. He teaches, he trains, he's got a long list of publications. He's an active BSSH member and a FESH member. He has won numerous research awards and grants and is a big contributor to the academic literature. Arguably his greatest accolade is being my drinking buddy on courses and conferences, and he's an old friend, so it's a great pleasure for me to introduce Nick. Actually, our first speaker is going to be Alice Bremner Smith, talking about acute fractures. So Alice is a senior consultant. She's been established at Chelsea Westminster for a really long period of time. She is an honorary senior lecturer at Imperial. She again is an active BSSH member, and she is the principal investigator for a number of trials. Alice's arguably, biggest accolade is being my former boss. She was actually my trainer and mentor many years ago, although interestingly, she kind of forgot about this during conversation the other day. So it tells you how much of an impression I made on her, and she's still probably revising the cases that I did for her as a fellow back in 2010. So thanks to Alice for coming along today as well. Our final speaker is Raj Bhatia from Bristol. Raj has been a consultant at Bristol for over 14 years. Again, he has been a faculty member for national and international courses. He's published, he's trained, and he remains an active Hand Society contributor within our network. Last but not least, our moderator and our chair for the evening is Professor Joe Diaz, who, if you are, within hand surgery circles, really needs no introduction. Joe is a professor of orthopedic surgery at Leicester. He has published perhaps over 150, 160 academic papers within the field of hand and wrist surgery. 30 book chapters, 25 papers on the scaphoid alone. He has been a chief investigator on so many trials, and he has written lots of nice pathways. He was the previous editor-in-chief of the Journal of Hand Surgery, on the editorial board of the Journal of Bone and Joint Surgery, and a past president of the British Hand Society. So an amazing list of accolades, and we have a fantastic panel. So without further ado, I will hand over to Joe, who will say a few words before introducing our first speaker, Alice.
Thanks, Raman. And thank you everyone for joining this webinar. The scaphoid fracture, the scaphoid is a unique bone in the wrist, and most people worry about it in some shape or form, whether you are in emergency department or a junior in training surgeon or a senior surgeon. So what we want to do today is just explore areas of the scaphoid. It's not going to be very detailed or very heavy. It's always difficult to be heavy after 8 o'clock in the evening in any case. But we want to invite your questions and your comments. So if you do have questions, put them in the Q&A, and there'll be natural gaps between the presentations for you to raise your questions. This is quite informal. So think about it almost like a chat in the pub, that sort of stuff. And if you've got any questions or any uncertainties or any challenges to any of our speakers, just feel free to do those. So without further ado, I'm going to introduce Alice to present the first part of scaphoids, which is acute scaphoid fractures. Alice.
Good evening. Can you hear me all right? I'm going to start the proceedings by talking about acute scaphoid fractures. I aim to cover everything I do actually know about them in about 10 minutes, so that we've got time to discuss a couple of cases at the end. So to start with, some things we do know are that these fractures occur in young people, typically in young men. And they can be, for some people, quite a devastating injury. And that's because they can affect people's careers, because the scaphoid bone has issues. And these are, scaphoid injuries can be difficult to diagnose. The scaphoid bone may have difficulty healing. And when it does have difficulty healing and goes on to nonunion, it does go on and cause further problems in the wrist. We know how these injuries usually occur. It's often a fall on an outstretched hand. The wrist is extended with a loading force through the forearm, such as happens commonly coming off a bicycle, or goalkeeping is another common cause. And one of the problems is that the diagnosis may not be that obvious. The signs can be quite subtle. Lack of a dip in the anatomical snuff box. So you get a bit of fullness, some mild pain, and some bruising. That may be all that people experience. So it's very important when examining somebody, if you have suspicions of the scaphoid, that you look specifically for certain things. And in my experience, one of the most useful, pertinent signs is tenderness on the scaphoid itself. If you palpate the scaphoid tuberosity, which is, you can feel it if you bring your hand from ulnar to radial deviation, the tuberosity will hit you, as we know, there on your thumb. If that is tender, then that's a good sign. Tenderness in the anatomical snuff box is commonly quoted, but the snuff box can be quite tender to palpation when there's nothing going on there. So if you have suspicions, it's important to follow those up with imaging to try and confirm or refute that diagnosis. And I think these days, we can agree that X-rays are not really, they're not good enough to definitively establish whether or not there is a scaphoid fracture. They miss a certain number of fractures. When I qualified, it was the gold standard to get X-ray scaphoid views and then get further views 2 weeks down the line. But these days, I think that is not good enough. And I think if you have suspicions, then MRI or CT scan is the way to go. MRI and CT are fairly, very similar as regards accuracy of diagnosing scaphoid fractures. They have their own pros and cons. An MRI is less radiation for the patient, and you get a lot of information about other injuries like bone edema, joint effusions, sprain type injuries of the soft tissues. A CT will give you information about bone healing and is good for looking at the alignment of the scaphoid. But basically, either of these is a good way of diagnosing the fracture if you are not sure. In my hospital where I work, we can get a CT scan as quickly as we can get an X-ray. So if I have a query, I will send a patient off to get a CT scan to find out whether or not there is a scaphoid fracture. And I might get an MRI if I want to look for other injuries. Is it a big deal to pick these up? Well, you have, the lawyers think so. You only look on the internet and these pop out immediately. And a lot of us may have, done a few reports where negligence has been sought for missing these injuries. So I think it is important to really try and establish whether or not there is a scaphoid fracture and not let patients go without being fully investigated. So why does the scaphoid have issues? Well, a lot of it we think is due to this rather lopsided blood supply. The blood supply comes in distally and then moves proximally, such that fractures in the more proximal part of the bone have a tendency to cut off their own blood supply. And there's an increasing risk of nonunion and avascular necrosis with fractures as you go more proximally. So how do you best treat them? Basically, there are two ways of treating a scaphoid fracture. You can either operate on it, or you can put it in a cast for a period of time. And there are pros and cons to these two techniques. And obviously, some are more appropriate for some fractures than others. But in general, a cast is good because it avoids doing an operation on somebody and all the associated complications therein. It can mean putting somebody in an immobilized position for a long period of time. So it may mean that they are out of function for longer. And you can create quite bad complications with a cast, especially if they're too tight. So they need to be appropriately applied. An operation has the advantage probably that you have done it, you have fixed the bone. So if you've done it properly and well, then, even if the bone fails to unite, it is stabilized, which is probably better than an unstable, ununited scaphoid. If you're brave and you think your fixation is good, you may be able to reduce the period of immobilization, but an operation creates a wound and there is a risk of significant complications from issues such as nerve injury, metalwork prominence might need to be removed, infection, general anesthetic, etc. So you need to think about these things with your scaphoid fracture, but there are, and there are certain types of fracture which very much lend themselves to one or other of these procedures. Casting alone is generally used for undisplaced, distally based fractures of the tubercle or distal pole, because they are highly likely to unite and do well with a cast. Operation, much more commonly used sometimes for undisplaced fractures in the proximal part of the bone, and for displaced fractures, which can be anywhere in the bone. There's another question, how displaced is displaced? Well, generally, perhaps we say more than 2 millimeters displacement. There are some injuries where you can go either way. And we know for an undisplaced waist fracture that approximately 90% probably unite if you put them in a cast for 6 weeks. And there was a lot of, a few years ago, there was an increasing tendency perhaps to think about operating on these to try to reduce the period of time people were in a cast. And so luckily for us, Joe Dias decided to undertake the largest randomized trial looking into the difference between surgery and casting for these fractures in adults. That said, it was actually looking at the difference between initially operating or initially treating with a cast and then converting to an operation if it looked like there was non-union occurring at sort of 6 or 12 weeks. But the value of this trial is that it did show that overall there was no difference in patient-reported outcomes at 1 year, that is wrist pain or function, grip strength, or range of movement. And it also showed that there was no significant difference in absence from work or time off work between the two groups, which is one thing that had been pushing the surgical side. It perhaps did show that fewer people in the surgery group had non-union or slight union of the bone, but surgery was more likely to lead to potentially serious complications. So in general, I think most of us have agreed that an undisplaced waist fracture would be treated in a cast initially. And then what most of us do is get a CT scan at about 6 weeks. And then if there are signs of non-union, think about operating then. You know, it may be you get your CT scan and there are some signs of union and you can leave them in a cast for longer and then rescan them further down the line. In general, as well, I would say most of us think that more than 50% union on a CT scan suggests that the fracture is probably adequately healed to start mobilizing. When it comes to operating, we have two main approaches. We tend to use the dorsal approach for proximal fractures between the second and third compartments on the dorsum of the wrist, and the volar approach for waist or distal fractures. And this particular approach is showing the ligament sparing approach that Mark Garcia Elias introduced. When you operate, if they're undisplaced, you can do them percutaneous. Or you can decide to do them open, and you can decide to add graft if there is a gap. I really don't think it matters how you decide to operate on your scaphoid. I don't really feel there's a huge advantage of percutaneous over open. You still have a small wound that is going to take about 10 days or 2 weeks to heal. But what does matter, I think, if you're going to operate, is that you make sure the bone is anatomically reduced, that there are no gaps between the two sides, that you've got good compression, that it's stable, and that you've buried the metalwork. And probably the worst thing that you can do is if you decide to operate on an undisplaced fracture and you inadvertently displace it. And so that's always something to think about when you're making this decision on how to treat these injuries. Is there a risk I'm going to make this worse? And you need to think about that before you go ahead and while you're treating it. So at this point, I just thought I'd talk through a case. This is a fairly straightforward case, but it did take me by surprise a little. This is a case of a 28-year-old man who I met about 8 years ago. He came to see me having fallen off a bicycle, I think. He wasn't particularly sporty, but he had a painful wrist, and these were his x-rays. And I was suspicious that he had a scaphoid fracture. So for some reason, actually, he had an MRI and a CT. I don't normally do both, but he did. But both on the MRI and the CT, this looked like an undisplaced waist fracture. The MRI confirmed there was no avascular necrosis apparently occurring in those early stages, and the CT showed good apposition. So we talked about the options and decided to treat this in a cast. And so we did so, and then I got another CT I think it was approximately 6 weeks down the line. And these were the pictures, and it looked quite good, and the radiological report was good. But I did think the lateral didn't look ideal. So we discussed the options again. I think he was not keen for surgical intervention. So we went back in a cast, and he stayed in a cast for another 6 weeks. And at the end of that time, he had another CT. And on this occasion, the CT did look better. The edges appeared to have sort of smoothed out on the cortical side. And on the lateral view, it looked good. And the radiological report was from the consultant radiologist was very good, and said it looked like there was clearly good union occurring. So he came out of cast and he mobilized, and I saw him after a month, and he was doing well. And then he did actually then go off and didn't come back to follow up. And I thought no more of it, and I was pleased with how things had gone until last year, when he came back to see me and said his wrist was hurting again. And I got an X-ray, and this was his X-ray. And it was clear that he'd got a non-union of his waist, of his scaphoid. And I remember feeling, pretty gutted and a bit of egg on my face, because I'd told him everything was fine when I'd last seen him. I got a CT scan, and this is what it looked like. So this, I then thought was a 8-year-old non-union of a scaphoid. He said he'd had no further injuries that he could think of. And so I assume this is an 8-year-old non-union. So I then had to decide what to do with him. And I just thought at this point, I might ask my fellow panel members how they would approach managing this at this stage. I'll talk through what I did, but does anyone want to just chip in and say what they would do?
Hi, Alex. Looking through your picture, I think you did all the right things to begin with anyway. And your CT, I think, was around about 8 weeks. It did look united to me, and the radiologist reports it as united.
Yeah.
The question arises, he may have had another injury, which you don't know about, which may have happened further down the line. The only way I differ in my management to what you did, I never keep anyone in cast for 12 weeks. I do a CT at around the 6 to probably 8 week mark. And if I feel there's not 50% union, then I'll go for a percutaneous screw in and undisplaced a fracture straight away. Because I think keeping someone in cast for 3 months is just, especially a young person with their occupation and everything, it's just far too much for me. And I've always made a decision at 8 weeks to fix or to get them going. The other thing, I don't work in the NHS anymore, so I can get MRIs, CTs whenever I want. But when I was working at the BRI, very busy fracture clinics, I'd always tell my registrars, you must bring back everybody, even when you think the scaphoid is united on CT, or actually not CT. If it's united on CT, it's definitely united. On the X-ray, if you think it's united, bring them back 3 months later and do another X-ray. And if you're worried, then do the CT at that stage. You couldn't really get CTs at 8 weeks. You're in the situation you're in now. It's 8 years since his injury, and he's got a lot of bone loss. There's a lot of cysts around there. And when you excise that, you will need a stable graft into it. Is he a non-smoker?
He's a non-smoker, yeah.
Is he, you're going to lose a lot of bone there because there's a lot of cysts there. And I would go, I wouldn't, he's in the waist still, and I'd go for more stability over vascularity in this. He's a non-smoker, he's fit and healthy. And I'll get a very good stable graft from the distal radius into there with a good compression fix. That's my feeling. But, I'm sure, others who are more into vascular grafts may say.
Anyone do anything different?
No, I'd do a non-vascularized graft for this. I think there's good trabeculae in that proximal pole.
Yeah.
Yes, there's big cysts, but I'd debride it back to really healthy bone surfaces. Take a good Palmer non-vascularized graft from the distal radius, curette out the base from where you've taken the graft so that you've got more cancellous bone, and pack it all up so that you've got flat edges, and then put the graft in and fashion it into a trapezoid shape so that you're looking to correct the deformity that's there in the scaphoid. And the patient needs to know that at 8 years, the success rate for non-vascular, for any graft in this kind of scaphoid is not great, but in the context of the fact that there's very little, if any, degenerative change there, that's what I'd do.
To couple of points. I mean, basically, I agree with what Nick's just said. But the important thing here is that there is very little arthritis around. So although you are focusing on the non-union, the bone quality of the proximal scaphoid looks reasonable. It doesn't look dense, doesn't look collapsed. So you know that there's going to be some vascularity there. And that is why I would completely agree with what Nick has said. So there is no arthritis and there's no collapse. So that is when you go in and stabilize with bone graft, which does not need to be vascularized. These views, Alice, don't show me that the scaphoid is flexed, but the appearance is anterior translation. So you are going to have, so you wouldn't just be going with cancellous bone. You probably need chunk of bone there to open up that scaphoid a bit. And I suspect if you showed us further views into the lunate, that it would show us that the lunate is tilted back.
Mm-hmm. Well, actually, I'm glad you all said that, because that is what I did. So I've just taken you through it. I mean, these are not pictures of me operating, because I don't have pictures of me operating, but this is exactly how I would do it. So I did a volar approach to the scaphoid, and I'm just showing these because they show the bits that I think are really important when you do scaphoids, which are, I think, what really matters when you're doing a scaphoid non-union. You have to take the scaphoid right back to the good quality cancellous bone that is there. You have to debride it thoroughly. And then I do, as shown here, I do make little K-wire holes in it just to really try and make it feel like something's happened, stir it up. And then I took a distal radius graft. And when I was showing this because when I do distal radius graft now, after many years of not getting very good quality graft, I use a K-wire, and I K-wire out the entire rectangle before I put an osteotome anywhere near it, because the osteotomes are always blunt. And if you just bang them into the distal radius, it just flattens the cortex down, in my experience. Maybe other people have lovely sharp osteotomes, but I have to almost K-wire the whole thing out. And then I'll use, I've got a little curved osteotome that I find very helpful for getting the cortico-cancellous graft out. And I spend most of my time and most of my stress is getting the distal radius cortico-cancellous graft out, because I think that's the hardest bit of the operation. I don't actually use a laminar spreader because I find they're too big usually to get in. So I'll actually use joysticks in the scaphoid. And I put a graft in, and a cortico-cancellous graft in. These are the views at 6 weeks. That's my little bit of cortex. This is a side view. It's not perfectly reduced, but that's the side view. So and again, so that's the side view. That's the cortex. This will be the cancellous graft, and the screw is going here. That's the sagittal view. This is the coronal view. The graft didn't go all the way across the bone, so there's a slight divot there, but this part looked healed. So he came out at 6 weeks, and he's got mobilized, and happily it went well. He clinically seemed to be doing well, and he was due to come back and see me actually on Monday, but he didn't come. So I hope he's doing well. But that was just a case, and it has made me. I think what I did when I saw him, I was very optimistic 8 years ago that he had healed, but now I always say to patients that the scaphoid is unpredictable. So, although it looks like everything is great, I can't absolutely guarantee they're not going to come back and see me at some point. And then I've just got one more case that I thought I'd show, because actually I'm doing this tomorrow. This is a case I've got to do tomorrow. This is a young man, an 18-year-old, who's a very keen sort of semi-professional sports player, and he has an acute fracture of his scaphoid, as illustrated here, which was sort of sold to me as a waist fracture, but actually I think it's a bit more proximal than that. And again, I just wondered, just with these images, how would others treat this injury? Would you go percutaneous? Would you put it in a cast, or would you put graft in? Raj, how would you treat this?
I would definitely fix it. And I would, when it comes to a dorsal, I better get my video up. When it comes to a dorsal approach for scaphoid, it's not really percutaneous. You've got to make a centimetre or so incision so you don't damage the EPL. So I look for Lister's tubercle. I go forward and I make a centimetre, maybe a centimetre and a half incision, because I want to make sure I'm not going to prang the EPL. So I get the EPL out of the way, and I get 2 cat spores, get my assistant to get 2 cat spores in. You've got to really flex your wrist up. That's the only way you're going to get in. And you got to, it's bizarre. The angle is actually quite acute. It's not straight on as you think it might be. So you've got to get the angle straight down, and you've got to go right down the fairway. I'd fix this because it is proximal. You're absolutely right, and I wouldn't treat this in a cast.
And would you put any cancellous graft in there as well, or would you just percutane?
No, it's acute. It's a fit young sports player. I don't think you'll need to. And a lot of these acute fractures, whether you're fixing a waist or a proximal pole acutely, there's often all you see is a fracture line in the cartilage. There is no gap.
Yeah. I think you'd have to make the gap, wouldn't you?
I wouldn't make a gap.
Make a hole to get in there.
I don't think it looks okay to me. I would just percutaneous fix it in an 18-year-old fit, healthy person who's not diabetic, not a smoker.
No.
That's my opinion. That's where I'd go. But you're right. And then I give them all the caveats: high non-union risk, this, that, the other. Protecting, no heavy lifting for 8 weeks or so, and I'll say all of that bump, and hopefully keep my fingers crossed.
Anyone else? Nick, would you do anything different? Joe?
I'd do exactly the same. I'd approach it dorsally. I'd consent him for graft, but I wouldn't necessarily use it. If he's consented for it and you get in there and there is something unexpected, it's an easy thing to take. I don't think I'd need to take anything cortical, so it'd just be cancellous graft in his distal radius. You get one chance to put a screw in the proximal pole, so make sure it's right.
Yeah, thanks. There are a couple of questions that we have, and I think we'll take. There's one from Ben Dean, and there was a comment from David and Tebby, and that is about your statement, Alice, where you said that the scaphoid X-rays are not good enough, and therefore we do imaging. But I suspect what you actually meant to say was that if the scaphoid X-ray shows a clear fracture, then you do not need any further imaging unless you want to establish displacement. The question that has been asked by Ben is to do with your statement that MR or CT is about the same. And he felt very correctly that if it is a suspected scaphoid fracture, that maybe the MR was better because that is what the systematic reviews have suggested. Have you seen that question on the Q&A?
I haven't seen it, no, sorry. And I probably haven't, it's not my area of expertise, I have to say, whether MRI or CT is better. My understanding is that, MRI, you may get more false negatives with CT, and you may get a few false positives with MR. But both of them are, yes. And what I was talking about was the fact that undisplaced fractures can be missed entirely on X-ray. So if you're suspicious, I just think you need to get more sophisticated imaging. And in general, I don't know, I think most of us, we routinely go to a CT scan, and we wouldn't, I think if I couldn't see it on a CT, I probably would, we wouldn't then go to an MR as well to exclude a scaphoid fracture. I don't know, maybe we're, behind the times, and we should be. But at the moment, I think as long as you get one of those, then you've probably taken things far enough.
Yeah, I think.
Would you disagree, Joe?
Not completely. I was just going again, just as Ben has done. You go with the evidence, and in fact, Sam Gidwani published his work on suspected scaphoid fractures, which show that if you are still concerned about the possibility of a scaphoid fracture, a suspected scaphoid fracture is a clear fall onto the outstretched hand pain, swelling, and tenderness in the anatomical snuff box, pain on ulnar deviation of the wrist. And this is Andy Duckworth from Edinburgh did the predictive modeling on this. And if you've got those signs, but the initial good quality x-rays do not show a scaphoid fracture. So that is how you define, Ben, a suspected scaphoid fracture. And if you have that, and you have all those factors, then you do an MR scan, you resolve the issue, and you then know whether it's a fracture or not a fracture, with the caveats that Alice has put in of a higher false positive rate with MR and a higher false negative rate with a CT scan. So you do an MR, you resolve the issue because the decision you need to take is, do you put this lad's wrist in a cast? And you can resolve that quite quickly doing that. So I think that will cover those two questions. I think I'm trying to see. I'll just share my screen, Alice, if you want to stop sharing yours.
Mm-hmm.
Okay. And just to, in fact, address the issue of why are we worried about scaphoid fractures? So the reason that we are worried about scaphoid fractures is if the scaphoid does not join, then it disrupts the whole proximal row of the wrist. And the wrist is quite peculiar, that the way it does it is you've got all the flexibility within the wrist to do your functions. And at each point of the wrist, it can suddenly become stable if you increase grip. Because what happens when you start squeezing something in the different positions is that the scaphoid flexes, the triquetrum moves into extension. So it's like a spring that tightens around the capitate, and you get a nice, solid, stable block on which to use your fingers to do tasks. Now, if you've got a scaphoid non-union, then you lose that Weiss mechanism. And if you lose the Weiss mechanism, then there's abnormal loading at the back of the wrist, and you wind up with arthritis. And that has been shown by a whole host of papers that within 5 years, about 95% of symptomatic non-unions have arthritis. So the first thing that happens is this correct? So this is data on just under 300 scaphoid non-unions. And what we're looking at, and these are acute, during acute management, and also late presenters. And on the x-axis is the time in years since the initial injury. And on the y-axis is the radiolunate angle. And this is when the lunate starts tilting. If it tilts more than 10 degrees facing backwards, that is called dorsal intercalated segment instability or dizzy. And what this graph shows you, that even before 1 year, most of the scaphoids are greater than 10 degrees. So you get a dizzy happening very, very, very early. Okay, and if you get this abnormal loading, then you're not surprised that you'll wind up with arthritis. I'm not going to spend too much time on this slide. This just shows you that the waist scaphoid is the one that gets the earliest arthritis, and arthritis starts within the first year. So it's not 5 years, because all that data was based upon x-rays. I just want to end up with this. This tells you the SNAC. I don't know whether you guys know about SNAC. It's scaphoid non-union advanced collapse. And that tells you that it's only on one side of the wrist, or it is into the mid-carpal joint, or it is all the three parts of the wrist around the scaphoid. And the important point here is that the functioning of the wrist, if you look at the PEM score, the PEM 0 is completely abnormal and 100 is completely normal. So you can see that the PEM is functioning at 43. So a 60 loss of function, even when you do not have arthritis. So just the fact that the scaphoid can't grip the capitate means the person has got quite significant impact upon them. So the whole aim of fixing is to try and restore the proximal carpal row. So we're not just trying to get the bone to join, but we want to restore that vice-like mechanism. And I think at that point, I'm going to hand over to Nick, who will talk about the difficult end of trying to get the scaphoid to join and tell us about vascularized grafts. Nick, I'll stop sharing.
So thank you very much. Thank you very much to OrthoHub for organising the event, and to Acumed for sponsoring it. Thank you to Ramon for the very generous introduction. The check's in the post. It's not a big check, but the check is in the post. So I've been tasked with talking about vascularized grafting and managing the unreconstructable proximal pole. So we'll start off with vascularized bone grafting, and the pedant in me needs to point out that it's not a graft. It is a local pedicled osseous flap. And I think early on, I should make the statement that I don't always use a vascularized graft. So the patient on the left has a 5-month-old proximal pole nonunion, and I treated this with cancellous graft from the distal radius and an antegrade screw. So I don't always vascularize my proximal pole nonunions. I think it's fair to say that I'm doing fewer waist vascularized grafts, and this was a 70-year-old gentleman who was fit, was cycling and was playing tennis, and he went to non-union, and I did a cortico-cancellous graft from his iliac crest, and he united. So I don't always vascularize. It's a dangerous slide to put up, a non-union philosophy slide, when the moderator is one of the sort of most important professors of hand surgery. But I think it is important to think about waist non-unions and proximal pole non-unions as different beasts. There are different personalities to the non-union. With a waist, you tend to get bigger anatomical abnormalities. You really have to make that fixation stable, and you have to manage the mechanics of this scaphoid that's trying to flex. With the proximal pole, we have to consider the vascularity more. And I think that what we should try to do is to move away from this binary avascular necrosis or alive proximal pole statement. And I think we should try to move towards using the phrase dysvascularity and bone healing capacity, because I think this gives you a much bigger spectrum of healing potential. This isn't a binary, there's all blood or there's no blood. So when I'm asked to talk about vascularized bone grafting, the things that people normally ask me are, why should I bother doing a vascularized bone graft? Well, there's heterogeneity in this population of non-unions. Not all non-unions are the same. So as a hand surgeon, you need to have multiple arrows in your quiver. And as I said earlier, you get one chance to put a screw in the proximal pole. So if you've got a non-union there, I personally feel that if you need to throw the kitchen sink at it, you should do. You should optimize the vascularity. You should get your stability as good as possible. And if there is some anatomy that needs correcting, then you should aim to do that. I'll talk about how I think it is reasonable to assess for vascularity. The other questions that are often asked is, how do I find this vessel? I've seen pictures of it in a book, but I've never seen it. How big can the graft be? And how do I make the pedicle long enough? I've tried to do it. The pedicle was too short. I couldn't get it in. So in 15 minutes, we'll touch on these things. So what does the data say? Well, there was 2 systematic reviews published in 2015 and 2016 from the UK. And when you drill down into the text of these 2 papers, they say very similar things. They show that vascularized bone grafting has slightly better union rates than non-vascularized bone grafting. But also in the more difficult non-unions to treat, so your proximal pole non-unions or your avascular necrosis non-unions, it seems that these vascularized bone grafting options have better union rates. Now, within these papers, you can see that there is almost an inclusion bias into some case series. If you have AVN or you have a high amount of proximal pole non-unions in a series, you see that these surgeons are more likely to use vascularized bone grafting. So automatically, you've taken the more difficult of the non-unions to treat, and you've used a vascularized option for them. So are we saying that actually if we use vascularized bone grafting everywhere, we get even higher union rates? I'm not suggesting that, but that's where the logic would go. This paper from New York, I think, is really interesting and in a way is very powerful because it strengthens the desire to not assess formally for vascularity. This was from Scott Wolf's group, and what they looked at was whether MRI scans and assessment intraoperatively for vascularity corresponded with histology. They also attached a small case series of 35 non-unions. And of these 35 non-unions, only 9 were proximal pole non-unions. So what their data says is that there is no association between MRI findings and intraoperative findings when compared with the histology of the bone taken out and sent off to the lab. They also looked at intraoperative bleeding that's present in the proximal pole, and there was no association between MRI findings and also the histological findings. So really, there is no point in requesting an MRI scan to request vascularity. There is no point in assessing punctate bleeding to see whether the proximal pole is viable. The paper goes on to say that therefore we shouldn't vascularize graft. And I think that that is a conclusion that is one step too far based on a small series of 35 patients, of whom only 9 have proximal pole non-unions. So how do I assess for vascularity? This is a small paper, 29 patients, and they looked at trabecular structure, sclerosis, and fragmentation of the proximal pole to help derive a decision to vascularized bone graft or non-vascularized bone graft. This is, small data, but I think it's an interesting approach. And these 3 are CT scans that I've just found going through my pictures. So the chap on the left has good trabecular structure, there's no sclerosis, and there's no fragmentation of the proximal pole. So he had a non-vascularized corticocancellous graft. The scan from the middle, the trabecular structure looks good. There is some sclerosis, but there isn't really any fragmentation. So this gentleman, for me, because of the fact that there was some sclerosis present in the CT, he had a vascularized option. And then finally, the image on the right is pretty obvious that this proximal pole is white. It doesn't look very healthy. So he also had a vascularized option. So what is my vascularized weapon of choice? Well, I used the Zeidenberg graft. This is probably the vascularized graft with most data in the literature. It's taken from the 1-2 intercompartmental supraretinacular artery. And you can take this as a corticocancellous graft and use it to correct anatomy in a kind of a Fisk-Fernandez type way, as demonstrated by the pictures on the right. So where's the vessel? So this is the Zeidenberg vessel. So hand is over here, forearm is over here, and this is the vessel. A useful marker can be the cephalic vein. This, as you raise the flap, this can be over the 1-2 ICSRA. And you can take a graft of reasonable size from there pretty straightforwardly. How big can that graft be? So this is a 8mm Lambots. gone into a depth of around a centimetre. I have to thank my colleague Ian McNabb for getting some smaller laminar spreaders that are pretty routinely used to help to open up a scaphoid. I find it's helpful to open the scaphoid up to allow the soft tissues to stretch out a little bit, and then it makes it more straightforward to get the graft into. And how do we make this pedicle long enough? Well, the irony is that the further proximal in the radius you go, the longer your pedicle becomes. So what I tend to do is I tend to measure about 8 millimeters from the tip of the radial styloid, and I start my graft harvest about here. And once this is removed, we can then take off the tip of the radial styloid, partly as a treatment of grade 1 snack, but also to facilitate placing that graft within the prepared area of the scaphoid. And I agree with Alice, this is a pretty stressful moment, right, getting this graft out in a block. It's pretty disheartening when it delaminates. One technical tip can be to make another little saw cut just at the edge of it, and then to put an osteotome in it to try and cleave it away from the bottom. Here we can see the graft being removed and is ready to be placed into the recipient site in the scaphoid. Orientation of the graft is pretty straightforward to remember. You just rotate it through 90 degrees and it fits in. The square area of the graft can also be chamfered so that you make a trapezoid shaped graft so that you can correct anatomy should you need to. And here's the graft in situ, fixed and out to union. So following this picture, we do sort of chamfer these little corners down so that we can make the scaphoid nice and smooth. Other vascularized options are available. This option from Dean Satirianos' group shows 86% union in 64 patients. It's a nice, straightforward graft to harvest. It doesn't correct anatomy, but is a powerful inlay graft that can be used to optimize vascularity. So let's move on to the unreconstructable proximal pole. So there's 3 patients here, one of which has been instrumented and 2 which haven't. And you can see running through the CT that this is a pretty small proximal pole. So what are the options? Well, we can always undertake a proximal pole excision. That's discussed in the literature, but we do have biological reconstruction options. The option with the most data is the medial femoral trochlear flap, followed by the costa chondral graft. Newer emerging options are the proximal hamate graft, which was sort of discovered in 2016, and the coracoid flap, which is my weapon of choice in Oxford. And then finally, we have an arthroplasty option. This is the APSI implant. It's a pyrocarbon lozenge, which can be used to fill up space when the proximal pole is being excised. So the MFT takes the branch, the transverse branch of the descending geniculate artery and a piece of the femoral trochlear that's attached to it. This flap option is well established, has the most data, got excellent union rates, improves carpal alignment, improves pain scores, and people have studied the donor site morbidity extensively in the literature. The knee proms return to normality, but there are reports of ongoing pain and sensitivity. The main users of this technique suggest that it shouldn't be used in people of a certain vintage and of those with a high BMI. This flap option has a 10% complication rate, but only 1 supracondyle femoral fracture has been reported in the literature. I think it's important to note that this flap option only resurfaces the radiocarpal joint, not the midcarpal joint. The costa chondral flap or graft was popularized by Mike Sandow. 2 centimeters of the 4th, 5th, or 6th rib is excised and then chamfered down to 2 to 3 millimeters. Perichondral sleeve is retained, and this allows the costal cartilage to sit in the gap left by the proximal pole. In 1998, Mike Sandow reported on 47 patients, demonstrated good preservation of carpal alignment, improved functional outcomes. It was difficult to assess union given the small amount of bony rib that is attached. Further smaller series have replicated these results, and in particular, the lack of progression to salvage surgery. There are concerns over potential pneumothorax, but these don't seem to be borne out in the literature. The proximal hamate graft is an attractive option. It comes from the same carpus. It allows you to use part of the palmar capitohamate ligament to either restore or to augment a scapholunate ligament reconstruction. CT topography studies show good shape matching, and cadaveric work shows that the osteotomy doesn't induce issues with carpal kinematics. There has been some anthropometric studies which has demonstrated maybe that some hamates don't perfectly fit the scaphoid, but this work is pretty still in its infancy. There are small case series of this hamate graft, and so far they're all showing good union rates. And then finally, the coracoid flap, which was developed by Henk Giel. Myself and Paul Monk, one of my registrar colleagues, did some shape matching work on this, and the blue CT image is the scaphoid and the silver is the coracoid. Here on the right, you can see a harvested coracoid on a mini C-arm, and it looks pretty scaphoid. We did some dot plots, and we superimposed half of the scaphoid with the coracoid tip, and it demonstrated good shape matching. Henk has also published the anatomical studies of the vascularity. I've spoken to him about the flap earlier today, and he says that he's now done 65. The clinical paper is ready to be published, and they've only had one non-union. And then finally, the APSI, which is an attractive option. It's a reasonably straightforward operation to undertake. Doesn't burn any bridges for salvage. This is a recent systematic review, 156 patients through various case series, and they show good post-op grip strength, good post-op range of motion. Some studies show a 10% dislocation rate, but so far, touch wood, I haven't had a dislocation. So what did I do with my 3 patients? So the first chap is young. He is a manual worker, and despite his early styloid beaking, it was felt that a biological option would be optimal for him. So he got a coracoid. The next gentleman is a little bit older than me. He works in an office. He wanted a quicker return to activity and reduced time in plaster, so he had an APSI. And then finally, this young chap is still a teenager. He has good grip strength. The wrist is a little stiff, but his pain is pretty well controlled, and he wants to carry on playing sports. He understands the risks of developing degenerative change. He understands the risks of potential carpal kinematics issues later. So for the time being, we're monitoring him and we're keeping a close eye on him. So in summary, we need to characterize the non-union, and we need to characterize the patient in order to optimize our treatments. I personally think we should be applying shared decision-making principles to both non-unions and to unreconstructable proximal pole patients. And there is no one-size-fits-all. So I have a case. So this is a 34-year-old chap who's a landscape gardener who has a mountain biking accident in 2010. And he has this injury and he's fixed. And he does really well. He's discharged, he's asymptomatic. He comes back to us having had a dog bite in July 2020 to his right forearm. He self-treats it. but 6 weeks afterwards developed pain, swelling, and carpal tunnel symptoms. So in September 2020, when we see him, he has an extended carpal tunnel approach, formal penisynovectomy, and an arthroscopic washer. There's some degenerative change at the radiocarpal joint, the proximal pole is soft, but the cartilage cap is intact. Multiple samples are taken. His histo is positive for infection, and they grow solely Bacillus sylvestris from one sample. He has 2 weeks of augmentin and settles. He comes back to us in October, having had 3 months of pain and clicking in the wrist. And this is his new up-to-date radiograph. So what would you do now? Alice, what do you think?
So yeah, interesting case. I'd have a think about it for a little while, probably. It's hard sometimes, isn't it, with these to make immediate decisions. I mean, he's already had, quite significant surgery on that scaphoid. And you need to talk to him about what he wants going forward. But it's painful at the moment, so you've got to do something. So, I mean, it's painful, presumably because that screw is sticking out and abrading the joint surface. So I think the least thing you want to do is take the metalwork out. And also, if is that the cause of infection?
So that I think is the $1 million question. Raj, what do you think?
Well, yeah, he's got an active infection, hasn't he? So I think the first thing to do is get rid of all the metalwork. That needs to come out. The proximal pole is more or less non-existent from where I can see. So you can just excise that, because you don't want to be putting an apsy in. You don't want to be doing scaphoid four corner or anything like that at the moment. I just take the metalwork out, just make sure his infection is settled, see where his symptoms are. But he's really heading, really for salvage if he continues with a lot of symptoms. But I think the metalwork needs to come out, but it's not going to be easy. Are the wires sticking out the scaphoid?
Yes, one of them was sort of on the radial border, and one was slightly more difficult to locate.
Yeah, I can see. Yeah. What did you do? Interesting.
So I have to thank Ian McNabb for this case, because he picked this up. It had been listed by one of our juniors for a denervation, and he picked it up in his pre-op assessment clinic, because we were COVID and it was all pooled list. He picked it up. So this was a case that he and I did together, because for my sins, I'm sort of a bone infection sort of person. So we took him back to theatre, and I removed the wires, and as I was taking out the screw, it broke. So I managed to get the distal bit out of the distal end, and what we ended up doing was cutting the proximal pole off so that we could take the pole out and the screw. And actually, the bit that we took out, we had to resect back further anyway, because it still didn't look particularly healthy. So what we did was, within in the hole where the screw and the K wires had been, we filled that up with Ceramate G, which is a gentamicin-eluting bone filler. And then we used arthroplasty cement and molded it into a sort of pseudo apsy, partly to try and fill the dead space to reduce the risk of the infection recurring, but also to try and give him something to stop his capitate collapsing straight away. His lateral's not great. So we sent off loads of samples. His histo was negative, and from his sonication fluid. So if we take a metalwork out, we routinely send it for sonication. So for those of the delegates that don't know, you place it into a bath of fluid, you pass ultrasound through the fluid, and it breaks up any biofilm that is on the implant, and you get really good sampling techniques. So it grew something called Micrococcus luteus, which is a soil or a human skin organism. And he had, because his bacteria was sensitive to gentamicin, which he had in him. He had a 3-week course of clindamycin. So, sorry, this should say January 2022. So he's now 5 months out and hasn't attended his last clinic appointment. So we'll be hunting him down.
Good. Thanks, Nick. I think you've given unique sort of experience on this, because it's not a common problem to get infection, but when it happens, it can be quite devastating because you get chondrolysis. And once you've got chondrolysis, then you go into the salvage mode. So it very appropriately steps us into Raj's talk on salvage. Raj?
Yeah, I'll share the screen now. Yeah, can everyone see my screen? Yes. So basically, I'm going to talk about scaphoid salvage. So what to do if the scaphoid non-union has been missed and has gone on to arthritis, or you've tried techniques to unite the fracture which have failed. So Professor Diaz has already mentioned scaphoid non-union advanced collapse, or we call that SNAC. And this is a specific pattern of progression of arthritis that happens once a scaphoid doesn't unite it. The lunate assumes an extended position because it's no longer restrained by the distal scaphoid, and we call that a dizzy deformity or a dorsal intercalated segment instability. And because of the abnormal kinematics and abnormal wear now that you have, you get early arthritis. And as Joe has demonstrated, that arthritis happens very quickly, much more than we used to think. So 3 stages have been described, and I think this description was based on X-ray in the past. And in type 1 SNAC, you get arthritis between the radial styloid and the scaphoid. And in type 2 SNAC, you get arthritis in the mid-carpal joint, but between the scaphoid and the capitate. And in type 3, the arthritis in the mid-carpal joint is more extensive and it becomes between the capitate and the lunate. But like I said, this was designed when we only had X-rays. Now we have the benefit of wrist arthroscopy. And I like to stage a lot of my SNAC and SLAC wrists before I make any definitive management decisions. And I know that from scoping that you can get radiolunate arthritis as well. So these patients often present with pain and stiffness and swelling, which is often on the dorsal radial aspect, because the majority of the arthritis is between the scaphoid and the distal radius, and it can be referred to as a ganglion, which has happened a few times to me. The diagnosis is pretty obvious when you take X-rays. I personally rarely use CT for this, but you can also use CT. One note of caution, it can be an asymptomatic incidental finding in elderly patients who have had a fall, and the pain is due to the acute reasons, and the arthritis is not often that painful. And in those instances, you can leave well alone. For treatment, we all know about conservative treatments. I'm not going into that, but steroid injections can be very helpful. And then we move on to surgery, and there's motion preserving surgery and motion sacrificing surgery, which ultimately leads to a wrist arthrodesis. I've already mentioned I would do a wrist arthroscopy. It's an excellent tool for really gauging the extent of the arthritis. You can also debride the joint at that stage and perform a synovectomy. And I certainly believe that with the experience of many years with my patients, that they do get some pain relief, and you can then sit back and decide the next step further down the line. But before I do any major surgery for wrist salvage, I tend to perform a wrist denervation because it's quite an easy operation to perform. And I would do this in patients who have a good range of motion, because there's no point doing it if they're already very stiff. And what I prefer is a partial denervation where I excise the posterior interosseous nerve and the anterior interosseous nerve in the distal forearm, just proximal to the extensor retinaculum through a 3 to 4 centimeter incision. You can easily find the posterior interosseous nerve by moving the tendons out the way, and it runs parallel on top of the interosseous membrane. You can take 2 centimeter portion out, cauterize the ends, then make a small incision in the interosseous membrane, and you'll see the anterior interosseous nerve running directly below, and you can excise 2 centimeters of that. Now, the nerves at this stage are only supplying joint position sense and pain fibers from the wrist, but the joint position sense doesn't really clinically matter. There is some thought that the anterior interosseous nerve may be supplying the pronator quadratus, but I've certainly had no problem doing this procedure. Some of my colleagues prefer doing a complete denervation, and that means multiple incisions around the wrist joint, where you try and take out all the articular branches to the wrist. I've tried that when I was younger, and I found that very difficult to do. I just prefer to do the easy operation. And in my experience, and I think the literature will bear this out, that 2/3 of patients are satisfied with this, and a third have no benefit. But the pain relief doesn't last forever, but it can give you a year and maybe sometimes a lot longer than that. Another option in the early stage, in stage 1 disease, when you have arthritis between the radius and the radiostylus and the scaphoid, you can do a radiostyloidectomy. And Nick mentioned doing that when he was doing the vascularized Zeidenberg graft to get his descetic grafting a bit more easier. You could do this either open or arthroscopic. I prefer the open method, but you must be careful not to take too much styloid off, because if you take more than 6 millimeters off, you can destabilize the ligaments, principally the dorsal radiocarpal, the radiocollateral, and the palmar radioscaphocapital ligament, and this can lead to wrist instability. You know, we've already mentioned excising the proximal pole of the scaphoid. You can also excise the distal pole of the scaphoid in early snacking stage 1. But you've got to make sure that more than half of the scaphoid remains, i.e. it's not a proximal pole fracture where you're taking more than half of the scaphoid out. And you must make sure that there's no capitolunate arthritis. It's very simple to do. You can combine that with a radiostyloidectomy, and good long-term results have been reported, but there is progression to midcarpal osteoarthritis. And then we move on to the procedures I think most people really know, which are the scaphoid excision, 4-corner fusion, and I'll talk a bit about the proximal row carpectomy. So in extensive disease, when the radiolunate fossa is not arthritic, and I do a wrist arthroscopy stage before I do any of these procedures, you can do a scaphoid excision 4-corner fusion. You've got to be careful with this operation because you must correct the dizzy deformity, or you put the lunate into neutral alignment with the radius. And you must prepare the bony surfaces very well. And I tend to always augment this with a distal radius graft because you must get a good fusion, especially the capitolunate joint. The problem with this operation sometimes is non-union of the lunar-tricutal joint. And if you get that, you can end up with persistent pain further down the line. Now I've been around a long time, and I've done most of the operations you see at the bottom. When I first started out in 2005 as a consultant, I was using K-wires, and I'd bury the K-wires, leave them inside the wrist for 8 weeks, then take the patient back 8 weeks later and pull the wires out. And I had some good results. And then the spider plates came out. I can't remember exactly when, but I did a lot with spider plates. The problem with spider plates is you can leave them prominent, and they can cause impingement, especially in extension of the wrist joint. So they sort of fell out of favor, but hand on heart, I didn't have too many problems with them. And I think most people nowadays use cannulated screws, and I use cannulated screws, and I prefer the leader redact screws, which are excellent for this type of procedure. And on the far end, you can see on my slide, I'm not sure you can see, but that is an absorbable a fusion plate with absorbable screws. I've never had the benefit of using that, but the advantage would be that you're not going to get any metalwork impingement with that. The other option is to perform a proximal row carpectomy. Now, this is a very easy operation to perform. It's quite brutal for a hand surgeon. You're just piecemeal chopping out. Well, I tend to do it piecemeal. Some people may want to take out the whole bones, but I have less patience, but it's more brutal than most operations us hand surgeons are used to. But it's very easy to perform. There's no metalwork involved, and there's no fusion involved. It's good in the early stages, stage 1 or 2, but it's contraindicated if you already have a capitolunate osteoarthritis, or you have osteoarthritis in the lunar lunate facet of the radius. So it's important before you do a PRC that you are certain that you have good cartilage cover of the capitate head and of the lunate fossa of the radius. And this is best achieved by doing a wrist arthroscopy, in my opinion. Other people may want to use CT for this. It's also important to have an intact radius scaphoid capitate ligament to prevent ulnar translocation of the capitate head of the radius. Oh, I've gone too far. Sorry, my computer's playing up. Yes, so the two commonest operations are scaphoid excision, four-corner fusion, and a proximal oral carpectomy. And studies have compared, there's many studies out there that have compared the results following these procedures, and the results are quite comparable. The problems with the scaphoid excision, four-corner fusion I've mentioned already is a non-union, principally of the lunar-trocruteral joint, and problems with hardware impingement. You also get reduced range of motion if you do not reduce the dizzy deformity. The problem with the proximal oral carpectomy, you get reduced grip strength because you are shortening your wrist joint and you're lengthening your tendons. There's also, in young patients, you get early progressive arthritis, and this is because it's a non-anatomic joint you're producing between the capitate and the lunate fossa. So this is what I do, and I think this is what most people do. If you're going to do a scaphoid excision four-corner fusion, you do it in the younger patients, more active patients, and patients who have capitolunate osteoarthritis. Whereas you can do a proximal oral carpectomy, someone who's more elderly or has a sedentary lifestyle. But there are some elderly people who are very active and use their hands a lot, and you may want to consider doing a scaphoid excision four-corner fusion in those patients. Like I said already, the proximal oral carpectomy can progress to arthrosis in the capital radial joint that you've created. And also with the scaphoid excision four-corner fusion, the similar things happen. However, they're not always symptomatic, and the literature shows that conversion to an arthrodesis happens in about 5% for both groups. And most people use an anatomical dorsal plate for a total wrist fusion with very good results, and Acumed are sponsoring this event, and that's one of the Acumed plates which I use quite regularly. But more recently, Skeletal Dynamics have produced an intramedullary nail for fusion, and this is distributed by Leader, and I've done this on 3 patients, and they've done very, very well. The reason for doing an intramedullary nail would be that you don't have prominent metalwork over the wrist, because all you have is skin and your bone and tendons, and you have less tendon adhesions. And the aiming devices on that intramedullary nail are actually quite good. So if you've not seen that, it's worth taking a look. I'm not going to talk about wrist replacement. That remains an option. I've done many wrist replacements in my time, but I think that's another Ortho Hub talk. Sorry about this. A quick thing on what are the future developments coming forward in scaphoid non-union that will negate the need for all these salvage procedures that I've spoken about. One of the things that are in development presently are 3D printed scaphoid prostheses. We've spoken about the APSI proximal pole, but that's just a pebble that you stick in, which has no ligamentous attachments and just rattles around a little bit. But I think the future is going to be far better prosthesis to replace the scaphoid, and maybe other bones in the carpus as well. And the second thing coming through right now is bioactive scaffolds for non-union. And I'll talk a little bit about both. With the 3D printed scaphoids, they are made out of titanium or PEEK, which is polyether ketone, and PEEK is also a material used for the Motec wrist replacement, which I've done quite a lot of. At the moment in time, looking at the literature, there's limited case reports for the titanium scaphoid prosthesis. You can attach that to the lunate by making a hole through the lunate and passing some tendon or some synthetic tape through the scaphoid and into the lunate. Case reports range from a year up to about 2 years with good early results reported in young individuals. Whereas PEEK, there are no case reports presently, but the advantage of PEEK in the experimental phase is that it's cheap to manufacture using a 3D printer, and the 3D printer can be sited in the hospital, whereas a titanium printer would have to be in an industrial facility. There are no, like I said, no results that I can find in the literature for PEEK, and my colleagues can correct me if they know more than I do about this. The idea is that by replacing the scaphoid, you could prevent progression to a snack wrist and the need for salvage procedures in the future. And talking about bioactive scaphoid scaffolds. So these can be patient specific, and they are made by using 3D printers to fit exactly the non-union gap that you have in a particular scaphoid. They're made out of something called PBT, which I have no idea what that is, and I can't even say, so I'm going to stick to saying PBT. So when the scaffolds are made, you can engineer screw tracks into the scaffold. So when you're placing it between the two non-union, into the non-union defect, you get a good fit, and the screw does not fracture the scaffold as it goes in. And you can seed the scaffold with stem cells that give you angiogenesis, bone growth cells, and also oxygenation to try and reduce a non-union. This is all in the experimental stage, but I'm sure over the next 10 years, these procedures, there'll be a lot more published on them, and in the future, there may be the norm, and we may never need to talk about salvage procedures again. I've got one quick case at the end just to finish off. So I'm not going to tell you what I did with this. Looking at it again, and this is a case I saw about 10 years ago. I think there's many different options, but I went down one route. I was just keen to see what route my colleagues would go down. This is a 45-year-old gentleman who's a rugby player in the past. He cannot remember, he's had lots of injuries as a rugby player, but got on with his life, and now was referred with pain and stiffness in his wrist. He's got 45, flexion, extension, full pronation, supination, and he was swelling of the dorsal radial aspect of his wrist. And this was the X-ray that we got. I don't have an laptop, it doesn't really show much. It shows everything you need to know. So it'd be interesting to know what Alice and Nick would do with this.
Thank you, Raj. So, yeah, this is a 45-year-old man.
Yes.
I mean, looking at the X-ray, it looks a bit arthritic in the radioscaphoid joint. So I'd be wary of carrying out a reconstructive procedure on the scaphoid now. I think maybe, I mean, it's borderline, but I think you've maybe gone past that. So I'd be advising him of other options heading towards salvage. But I might, depending on his symptoms, as you say, there are various ways you can go. You can combine, so if he was wanting a procedure, I might be thinking more along the lines of a styloidectomy and a denervation, or you might want to add in taking part of the scaphoid out. But if you do those kind of procedures, obviously warning him that further down the line, he might need to have something else done. And so I think it would depend how far he wanted to go at this stage. And I think you need to have that conversation. You basically need to give him a brief summary of your talk,
Yes.
and see how far he wants to go, or if he wants to have something done now that's going to last him forever. And that would be my approach to it.
Yeah, Nick, what's your feelings?
I agree. I think the scaphoid is probably a touch too far gone to reconstruct. I'd get him a CT scan to look at the scaphoid in more detail and to just assess the carpus in more detail. But what I tend to do for these patients who are reasonably fit and reasonably young is I'd do an PIN blocking clinic, and I'd do pre and post grip strength. And that's sometimes really helpful because it gives them a marker of how much they could potentially improve with the surgery. And then the final thing that I'd do is if he when he was radially deviating, if he's getting impingement pain, then I'd do a denervation and combine that with a radial styloidectomy in the first instance. You've not burnt any bridges. The denervation data says that if it's going to fail, it tends to fail early. So I don't necessarily buy into the if you denervate somebody, you're going to miss an option. You're going to miss a preserving option. So that would be my thoughts about him.
Yeah. So it's about, I did a denervation PIN AIN, which you did well for about a year or so. Then I went straight for a scaphoid excision 4-corner with the round the circular plate, which I had an old X-ray from. But I wonder now, looking at it after all those years, whether I should have just done a combined with a radial styloidectomy with the AIN PIN. But there's lots of ways to go, which is why I wanted to put this slide up. But you're right, the thing is to talk to the patients and not burn your bridges, and you can go in a stepwise as a sort of progression. I just wonder what your thoughts were, Joe. Anything, final thoughts on this?
By and large, I agree with what you guys are saying. I think Alice, I think, has got it. I would be doing what Alice has said, and the reason really is that this lad seems to have reduced capitolunate joint, so with a skipped scaphocapitate joint. So it's not so you've got a SNAC 3 really here, but you can still manage this really in a sensible way, because the non-union is quite distal, and because it is distal, the impaction for a stage 1 SNAC is quite low. And I think the important thing about differentiate, when you look at SNAC and arthritis, they are two different things. SNAC is about the geography of arthritis, whereas arthritis is the severity of arthritis. So when you look at the the capitolunate joint, it is probably grade 2 arthritis. And your CT scan will give you more information about that. But basically, you would do what Alice has said. You want to get pain relief. So you've switched your mode from retaining wrist function to relieving pain. And when you are relieving pain, then you decide what is the most efficient way that you're going to relieve pain. I think I'll just share, if you want to go down, I'll just share, and I just want to make just one point on salvage, which is, yeah. Sorry, this is not the one.
Joe, whilst you find your slide, I promised I wouldn't jump in and say anything on this webinar, but I just couldn't really help myself towards the end. I'm just going to make one comment on the previous case that was highlighted. One option that hasn't really been discussed is excision of the distal scaphoid. And in a long-standing non-union where the level of non-union is waist or more distal, there are actually papers with a 20-year follow-up of distal scaphoid excision. So when the degenerate or the level of degeneration is limited to the level of the scaphoid, the radial styloid, and the scaphoid facet is relatively well preserved, or your midcarpal joint is well preserved, the results from distal scaphoid excision are actually really, really good. And it's an operation that I have been doing with increasing regularity for that patient group. I'm going to credit my American buddy, Louis Catalano, who was instrumental in writing one of the papers. In fact, both of the papers that were instrumental in changing my practice, and they included the 20-year follow-up, and they're from the same unit as Eaton and Littler in New York. And effectively, you can still manage to keep someone's wrist going, improve their pain, and maintain the range that they have by doing a relatively simple operation. And you simply just excise the distal pole, what's left of it, and the radial styloid. And
that was my point exactly, Ramon, because, like I said, I've done a scaphoid excision 4-corner fusion. Looking back many years later, I wonder whether that's where I should have done, excised the distal scaphoid and done a radial styloidectomy.
Yeah, I've been
you burnt no bridges then. You burnt no bridges. That was my point exactly, why I wanted to show that. So it's quite an interesting a case.
But I will urge everyone to think about that as an option, because it's you know, in my limited series of like a few, it's been a bit of a game changer. So I'm going to step back and let Joe continue.
Seem to be having a problem here. So let me just try. Can you see my screen? I'm not sure.
Yes.
And what can you see? Can you see the surgical options?
Yes.
Yes, the surgical options, it says pain, and there's 5 pictures and then a chart.
Excellent. So these are the surgical options that Raj has just mentioned. And as I said, all these surgical options will firstly improve pain. You know, with 85% will be reporting relief of pain. And we do it just as Raj has said. We do it for 2 things. We want to keep stability, and we want to keep dexterity. Those are the 2 things that we want. So we choose a PRC, for instance, a proximal row carpectomy here, because the recovery rate is very quick. But when you do a 4-corner fusion over here, then we know the recovery rate is quite prolonged, because you're waiting for bone union to happen. And I just wanted to share with you this. So this is about movement, okay? And when you move your wrist, and if you look at the tip of your finger, it will form a circumduction loop, okay? And then what you will see is this, and this is a normal wrist. Now, when you get an arthritic wrist, that is your range of movement. You've lost that inclination or the dart throwing motion, and it becomes just an up and down, like a knee or an ankle, okay? So that is what happens. Now, when you do a PRC, you restore the dart throwing motion, although the amount of movement is very, very tiny. When you do a 4-corner fusion, you've still got just a knee up and down. Do you see? And when you look at a 3-corner fusion, which is a capitolunate fusion, described by Greg Baines from Adelaide, then you have a better, you get a better position of this. If you do a total wrist replacement, then all you get is up and down. You have recreated an ankle, not a wrist. Okay, so that is the first thing. The second thing that Raj said was, what about strength? Okay, and then if we, all of us have used dynamometers for strength, and we've got a few therapists in the audience as well. So this is normal strength, and what this shows is maximal strength. This is what we measure in clinic, and that is about 35 kilograms there. But within about 10 to 15 seconds, this goes down by a third, so it's only 20 kilograms. So that is your working strength, okay? So if you ask them to sustain grip. So this is normal. This is the arthritic wrist, which is half strength. This is the PRC, quite good peak strength, but very rapidly the same as an arthritic wrist. This is a 4-corner fusion. Okay, and by, when I'm saying this is groups of patients, about 50 patients in each group, okay? Now, this is a 3-corner fusion, no difference in strength from a 4-corner fusion, although the dexterity is better. And this is a total wrist fusion. The one that we thought was going to give us the most strength gives us no benefit in strength. And finally, what do you think about wrist replacement? You know, we all know that we think of it as good as a knee replacement, as good as a shoulder replacement. This is the wrist replacement. So whatever salvage we do not reconstruct the wrist. We improve the pain, but we do not reconstruct the wrist. And it makes sense, because we're not changing that twisting motion we're not recreating the twisting motion of the proximal carpal row. So whenever you put in an apse or a total scaphoid, you're actually not recreating the proximal carpal row. Do you see? So if you're doing just a pain relief, if you're doing something only for pain relief, then you need to be aware of these other things, because you need to be explaining that to the patient, that your strength is not going to change, your dexterity might be reduced, you see, but your pain will improve. I can guarantee in 85% of my patients that their pain will improve. So then you do the simplest intervention that will get you the pain relief. If there's no difference between groups, then why put them through 3 months of recovery to get bone union at the mid-carpal joint? Going back to what Alice said, which is to do a denervation and not worry about the mid-carpal joint. In fact, the mid-carpal joint is very easy to reconstruct, because if you do get arthritis there, you just put in a pyrocarbon button, So, and if, for instance, you've done a PRC and you get arthritis, which usually happens at about the nine-year mark, then you can still just put a pyrocarbon button. So you got a plan B worked out, which does not need a fusion, a total wrist fusion. So that would be something maybe that all of us need to be looking at, and we just need to go back to our data to be able to say these things. And I think the good thing is the discussion has clearly outlined an important need, that we need a registry of all these salvage options, because we are still doing things that are not quite logical, because we're not trying to reconstruct the proximal carpal row. And for the younger consultants and the younger trainees in this group, that is where our research effort needs to be, is how do we restore that proximal carpal row? How do we manage low grades of arthritis? So that is where I think the next 20, 30 years around this topic needs to be evolving. I think I'll get Ramon in again and stop sharing my screen. Ramon.
Joe, thank you for your insights, and I think I completely agree with the points that you have raised. In that, I think that we need to take a completely different, a very different look at how we approach these problems from a salvage point of view, and they're probably really not as good as we've always convinced ourselves that they are. And data collection on a wider, bigger scale in a registry is probably the way forward. And I hope that younger surgeons like Nick and Raj and Alice take this forward. And on that note, let me just say a big thank you to the panelists, to Alice, to Nick, to Raj, and of course to you, Joe. I've really enjoyed it. I've actually learned quite a few things myself today, and it goes to show that no matter how experienced you are and how much you think you've kind of heard it all before, you actually just frankly haven't. I hope that the audience have enjoyed it as much as I have. I'm sure that they have. Again, a great big thank you to you guys as panelists. I hope you've enjoyed being on the panel and enjoyed sharing the discussion. So with that, I'm going to say thank you again. Good night. To those people who are watching, who think that their colleagues or friends might be interested, we're going to put all of this out onto our YouTube channel. It will be available to view again and to go through the slides one by one, or some of the points that have been raised. And of course, everyone's available to be contacted if you've got any specific questions. So thank you very much indeed, everybody. Thank you again to the panelists. Have a good rest of the evening.
Cheers. Thank you. Bye.
Thank you.